Welcome to the Home Hospice Association's Compassionate Caregiving Program. You have taken the first step in providing care for people in their most challenging and difficult time. Undoubtedly, though, the reward for doing this work will far exceed what you give. Objectives of this training program are to learn about the physical, mental, emotional, and spiritual needs of the dying person and their families, to contemplate your own thoughts and feelings about death and dying, and to develop an understanding and respect for the thoughts and feelings of those facing death. To learn the art and skill of compassionate communication and how to be fully present, hold space, and the meaning of sacred silence. To explore ethical issues, boundaries, and confidentiality. To learn about legacy and why it's so important to some. To explore your own spirituality and learn how to help people cope with loss. To learn importance of self-care, examples of it, how to integrate it, and healthy ways to deal with the stress of caring for the dying and their families. There will be no final mark at the end of this training. However, all modules must be completed in order to receive a certificate and become an active compassionate caregiver within Home Hospice Association. Although not mandatory, we request that the course evaluation at the end of the course be completed. Module 1, Introduction to Hospice Care. Learning objectives of this module are the history of hospice, some examples of life-limiting illnesses, the key concepts of hospice palliative care, what an interdisciplinary team is, and each role within it. Each role within the interdisciplinary team is unique and equally important to ensure the full circle of care that is the foundation of Home Hospice Association. Through learning, reviewing, and integrating the core concepts of hospice palliative care as taught in this program, you will be equipped with the necessary skills and knowledge to compassionately support and empower people with terminal illnesses and their loved ones. Defining hospice. Hospice is not a place, but a concept for healthcare delivery to those dealing with life-limiting illnesses. Through a range of medical, nursing, psychosocial, and spiritual care provided by an interdisciplinary team of experts, hospice seeks to manage symptoms and provide comfort. Life-limiting illnesses may include all forms of cancer, congestive heart failure, COPD, and neurological illnesses such as Alzheimer's and ALS. In addition to the diseases that children share with adults, children die from far more rare diseases. Hospice versus palliative care. The words hospice and palliative are often used interchangeably. The Ministry of Health and Long-Term Care deems a patient as palliative when they are in their last year of life. Hospice supports a person and those who love them from diagnosis. Hospice is less interested in when someone is going to die and more interested in how they are going to live with the diagnosis. Someone may live 30% longer if offered hospice care at the point of diagnosis versus in their last year of life for those times when treatment, care, and endless medical interactions are becoming physically and emotionally draining. Emotions are low and a vacation from illness is needed. Curative options have been exhausted and the doctor suggests it's time to put affairs in order. It appears it may be just days or weeks left. Families decide that the time remaining needs to be spent engaging in quality moments, which requires having others attend to the basic needs of food, shelter, and cleanliness. During those final days and weeks, the mystery of life becomes a topic that may be important to explore. Someone is actively dying. A grieving family member requires emotional and spiritual support. What is hospice palliative care, and why is it so important? Hospice palliative care is a special concept that was designed to provide comfort and support to people when a life-limiting illness no longer responds to cure-based treatments. It is countercultural in the sense that Western culture is geared to fight for life, while hospice palliative care neither prolongs life nor hastens death, but rather aims to relieve suffering and improve quality of living and dying by offering comfort and dignity. Western culture hides death and dying, while hospice palliative care moves towards dying. Hospice palliative care is provided by an interdisciplinary team that includes medical professionals, family members, friends, and volunteers, and aims to treat all active issues. Each person involved in the care of a dying person has a very special role, and each person will have special skills to meet the needs of a terminally ill person. Hospice palliative care focuses on quality of life while accepting the inevitability of death for both clients and their loved ones, and promotes opportunities for meaningful and valuable experiences, personal and spiritual growth, and self-actualization. Hospice and palliative care both provide interdisciplinary approaches that are holistic and supportive to clients and families, as well as offering bereavement care for the family after death. Support for caregivers and grief support for loved ones following death are both essential pieces of care for the dying. Key concepts of hospice palliative care. Most medical professionals strive to treat and cure pain, disease, and illness, but because palliative care is designed for people who are no longer responding to such treatments and facing the end of life, the concepts for palliative care are very different. Some of these concepts are: the dying person has the right to be in control of their life, and this includes continuing treatment or refusing treatment at any time. Death is acknowledged as a natural part of life, therefore treatment is considered comfort-oriented, and pain and symptom management is predominant. Consistency and coordination of care between all caregivers is essential, as the needs of the dying are often very diverse and can be managed best within a circle of care. Family is included in the unit of care with the dying person. Family is whoever the dying person says it is, whether it's a blood relative or not. This is their journey, and it affects everyone around them. Providing grief support for families before and after death is an essential part of care for the dying, as it can provide some relief to know that their loved ones are cared for and will continue to be. What is an interdisciplinary team? An interdisciplinary team is a team of caregivers from different backgrounds and professions who work together to provide services and collaborate care. Caregivers on this team could include a physician, nurse, dietitian, physiotherapist, occupational therapist, alternative medicine therapist, personal support worker, social worker, spiritual advisor, and volunteer. There could be role sharing or overlapping, but the team all works together to meet the needs of the dying person and their family. These primary members and roles can include a case manager. Through thorough discussion with the client and their family, the case manager establishes what the client's goals and intentions are based on resources and options available to them. Based on that initiative, the case manager will form a team to begin services, order necessary equipment and supplies, and respond to the changing needs of the client and caregiver as needed. Family physician. The family physician coordinates and assumes responsibility for the medical care of the dying person, and offers a listening ear and a compassionate response to their needs. The family physician is also responsible for discussing advance directives with the dying person and their family. At the time of death, the family physician will attend to the death certificate, possibly facilitate the transfer of the body, and provide support to the bereaved family. The nurse. The nurse works closely with the dying person and the family to assess needs and goals related to comfort and coping, and the effects of weaknesses and decreased mobility. The nurse plans, implements and evaluates, and performs interventions such as medications, injections, wound care, catheters, etc., based on the assessed need of the dying person. Personal support worker. The personal support worker assists with the daily activities of living, such as hygiene and personal care, toileting and bathing. The personal support worker observes changes in physical symptoms and emotional responses of the dying person and their family, and reports those to the case manager, nurse, and doctor. The personal support worker may also provide some light housekeeping, laundry, shopping, and respite if approved by the case manager. Spiritual advisor. The spiritual advisor assesses the spiritual needs of the dying person and their family and provides support in their search for meaning and hope in the changing circumstances. Spiritual advisor provides opportunities for meaningful rituals and prayers and may provide counseling. The spiritual advisor can assist the the client and family with planning a funeral or a memorial service. If the dying person has a faith connection, the spiritual advisor can liaise with their faith leader if directed to do so. Social worker. Social worker assesses the psychological needs of the dying person and family. The social worker provides counseling as needed, individual, marital, and family, to the client and family. The social worker can assist with practical needs such as finances, will, power of attorney, and funeral planning. The social worker provides bereavement support to loved ones. Palliative care physician. The palliative care physician acts as a medical advisor or consultant to other hospice palliative care providers, as the palliative care physician has current and in-depth knowledge of all aspects of care of the dying person and their family, especially in pain and symptom control, community resources, ethics, and client and family support. The palliative care physician works with, not in place of, the family physician. Depending on circumstances, other possible professionals include dietitian. The dietitian assesses nutritional status and develops a nutritional care plan to meet the changing needs of the dying person. Occupational therapist. The occupational therapist assists the dying person in maintaining quality of life through enabling them to achieve goals related to daily activity, self-care, productivity, and leisure. Physiotherapist. The physiotherapist improves mobility, provides pain management, and helps with respiratory function and maintenance of skin integrity. Respiratory therapist. The respiratory therapist addresses difficulties with breathing and develops a plan to optimize comfort accordingly. The respiratory therapist is responsible for educating the dying person, their family, and other team members on the operation, maintenance, and precautions of equipment. Speech-language pathologist. The speech-language pathologist assesses communication and swallowing needs, and as such, strategizes to meet the needs of the dying person as they change. Complementary or alternative medicine therapist. Complementary or alternative medicine therapists may be involved in symptom management of the dying person and also provide services to their family. Some examples of this are homeopathy, naturopathy, reflexology, massage therapist, energy healing, and acupuncture. Some additional acronyms and their meanings. CCAC, Community Care Access Center. LHIN, Local Health Integration Network. HPCO, Hospice Palliative Care Ontario. CHPCA, Canadian Hospice Palliative Care Association. In Module 1 you learned the unique roles within hospice palliative care, the importance and need of hospice care, who you will meet on your caregiving journey, your role within the circle of care. Congratulations on completing Module 1.